All right, good afternoon, everybody. I'm Dr. Jamie Mitchell, an endocrine surgeon. I'm the medical director at the Norman Parathyroid Center and the director for the Division of Parathyroid Surgery at the Hospital for Endocrine Surgery in Tampa, Florida. Thanks to everybody who's joined us for this live question and answer session about parathyroid disease. We're having our first ever Hyperparathyroidism Awareness Day today. This is an education and awareness initiative that we're doing, and it's in partnership with a lab test corporation called Any Lab Tests Now. This is a corporation that provides lab data where anybody can go and get specific labs drawn. You do not need a doctor's order to get labs. We decided to partnership with them because a lot of patients we hear have a hard time getting their doctors to check these lab data specific to parathyroid disease. And so we're excited to work with them and to provide more access for patients to get their labs checked when they're concerned about this disease. Thanks to everyone who's joining again, who's been to previous sessions, and welcome to everybody who's here for the first time. Hopefully you'll find it helpful. We got a lot of great questions, as we always do, and so sorry for the little bit of a delay. We had a little technical issue, so we will get started, okay? We're going to start with kind of a general question just because of Parathyroid Awareness Day, which is, and this is a question that came in actually, what do the parathyroid glands actually do? The follow-up to that is, are they related to my thyroid? It's a good question, and it's a good way to kind of just introduce parathyroid physiology and parathyroid disease. So parathyroid glands, or I should say that we are born with 4 parathyroid glands. They're near the thyroid gland in the neck, but it's important to know that they're not related to the thyroid functionally in any way. The glands are quite small when they're normal. They're about the size of a lentil or a grain of rice. So they're quite small, and they really have only one job, which is to regulate our calcium levels. Specifically, parathyroid glands correct, or I should say they secrete a hormone that corrects low calcium levels back to normal. And that's all that they do. All 4 glands do the same thing, and interestingly, one gland does as good a job as all 4 of them. And so in some people, it's more common in women than men by about 3 to 1, and the peak incidence of this disease, which is called primary hyperparathyroidism, are women in their 60s or older. And typically what causes hyperparathyroidism is a benign tumor called an adenoma develops in one of your 4 parathyroid glands. And as the tumor cells divide, and there are more of them, you make more and more parathyroid hormone, inappropriately so. Not when you need it, but just all the time. And so when this happens and you overproduce this hormone, instead of correcting low calcium levels back to normal, your calcium levels become elevated. And so who cares? Your calcium's a little high. Why do we care about that? Who cares? Well, there are consequences to having high calcium over time. A number of negative health consequences or end organ damages can occur, including increased risk for having a stroke or heart attack. This is because hypercalcemia can accelerate atherosclerotic changes in those vessels to the brain and to the heart. Having hyperparathyroidism and hypercalcemia can damage your kidneys by spilling more calcium than usual through the kidneys' collecting systems. And one of the ways that parathyroid hormone makes more calcium available in your bloodstream is to activate cells in the skeleton that then dissolve your bone mineral. And this is okay in little bits when you need it, but when you're overproducing parathyroid hormone, this is happening constantly. And so this leads to accelerated bone loss and osteoporosis. So that's just a sort of a general review of parathyroid physiology and what parathyroids normally do and what parathyroid disease is. So we'll go on with some of these other questions. My DEXA scan shows osteoporosis. DEXA scans are x-rays that measure your bone density, for those who don't know. My DEXA scan shows osteoporosis and my calcium is high. Shouldn't my bones be strong if my calcium is high? I don't understand. This was kind of answered when I did that. That's why I put these two questions together. The description or the explanation of what parathyroid hormone normally does sort of answers this question. But to repeat, when you have hyperparathyroidism and overproduced parathyroid hormone, that hormone activates cells in the skeleton. They're called osteoclasts. Usually they're dormant, but when you secrete parathyroid hormone, that hormone activates those cells. Those cells secrete enzymes into the skeleton that then break down or dissolve your bone mineral, and that releases calcium into the bloodstream. So if you have hyperparathyroidism, that high calcium is not good for your bones. It's coming from your it's coming from the bones. Hopefully that helps you understand, why it's a bad thing to have hypercalcemia in the setting of hyperparathyroidism for the bones. It's it's like a pretty common question actually. Does the size of a parathyroid tumor correlate to the amount of excess parathyroid hormone it releases? The short answer is not really. It doesn't really correlate very well. Fairly small parathyroid tumors can lead to very high numbers and vice versa. So we really haven't found a good or sort of a consistent correlation between size of tumor and how high your calcium is, how high your PTH is. It's a common misconception that how high your calcium is means you have worse parathyroid disease, but that's not really the case. The severity of parathyroid disease really comes from how long you've had it, which is why we advocate not following or watching the disease, but treating it once it's diagnosed. Next question. What happens if there's a delay in removing the parathyroid tumor? Will it just continue to get bigger and cause more problems? I sort of answered that with the previous question. Again, the severity of parathyroid disease isn't really how high the calcium is. In most cases, even for people who've had the disease for a number of years, calcium doesn't kind of keep climbing. It usually only stays, in most cases, 1 or 2 or a few tenths of a point above normal. But it's not really how high, as I said before, how high the calcium is. That's the problem, or denotes the severity of this disease, is how long you've had it. A good analogy for this is high blood pressure. High blood pressure causes a lot of the same problems that hyperparathyroidism does. Increased risk for stroke and heart attack and renal failure. But it doesn't, happen overnight. A day or a week or a month of hypertension doesn't cause those problems, but over time it does. Same thing with parathyroid disease. The longer you have it, the longer that it can, more chances that it has to damage your end organs. This is a great question. We get this quite a bit, and it's a common error. The question is, I have hypercalcemia, but my parathyroid hormone level is in the normal range. So my doctor says I do not have parathyroid disease. Is this correct? Probably not, is the short answer. It's a really important point, and it's a common error that's made by doctors in the evaluation of people for possible hyperparathyroidism. About 20% of patients with parathyroid disease have parathyroid hormone levels that measure within the normal range. They're not frankly elevated, or they don't measure above what the normal range is in the assay for parathyroid hormone. However, the only reason you secrete parathyroid hormone is when your calcium is too low in the bloodstream. So when you're hypercalcemic, if your calcium levels are measuring high, even having a mid-normal parathyroid hormone level is abnormal. It's inappropriately normal. Again, the only reason you secrete that hormone is to correct low calcium back to normal. So if your calcium is elevated from some other problem not related to your parathyroid glands, for example, your parathyroid glands don't have any reason to secrete parathyroid hormone. It should be very low, usually in the single digits or the teens. So if you have a calcium of 11, which is high, and your PTH is 40 or 50, which is in the normal range, quote unquote, you have hyperparathyroidism. Okay? That's one of the common errors when evaluating people for this disease. It's a great question. Next question, does hyperparathyroidism ever resolve without surgery? The answer is no. Two things to, I guess, discuss with this question is, parathyroid disease does not go away. It's typically, as I said, caused by a benign tumor developing in one of your parathyroid glands, sometimes more than one. And tumors don't just go away. So if you develop a tumor, they remain present until they're surgically removed. And there is no, the other point I was going to make is there's no medical therapy for parathyroid disease. Okay, there's no pill you can take or medicine that controls this disease. It's a surgical disease. So if you have it, the only way to treat it is to figure out which of your parathyroid glands is the problem, has the tumor, and to remove it surgically. Here's an interesting question. Can someone have both primary hyperparathyroidism and secondary hyperparathyroidism? It's kind of a complicated question to answer, but there's a point I'd like to make. The short answer is, yeah, you can have components of both, actually. But one of the reasons that I thought it'd be good to talk about this question is that a common problem or a common error that we see when evaluating someone for parathyroid disease. I actually had a patient in clinic today whose doctor told them this exact thing. And this is when people are found to have a high calcium, the doctor does a workup and they check a PTH, and their PTH or parathyroid hormone levels are high as well. So high calcium, high PTH. And often doctors will check a vitamin D when evaluating people for this, and they find that the patient has a very low vitamin D level, 25 hydroxy vitamin D specifically. And they often will tell the patient, we need to replete your vitamin D to make sure you don't have secondary hyperparathyroidism as well. And so that is a mistake. Having a low vitamin D or vitamin D deficiency is a cause for secondary hyperparathyroidism or a secondary elevation of your parathyroid hormone levels that's not due to parathyroid disease. However, when your calcium is elevated, you cannot have secondary hyperparathyroidism due to vitamin D deficiency. So the real answer is you can have components of both, but the reason I brought this up was to, again, point out this common error. If you are seeing your doctor for high calcium and high PTH and they want to replete your vitamin D to make sure it's not secondary, please don't proceed with that. That's a waste of time, and repleting your vitamin D aggressively can actually be detrimental. It can make your calcium go up even higher. That's a good question, though. Next question, can you live without any of your parathyroid glands? Yeah, you can. You can live without parathyroid glands. It's not advisable. It's not what we want. It's its own problem, can cause its own set of symptoms. It's not particularly good for you. You can live without them, but again, it's not advisable. So, for example, any parathyroid operation that we do, the goal of the operation is to, of course, cure the hyperparathyroidism while preserving normal parathyroid function. A common question we get is, well, what if all 4 glands are bad or abnormal? Do you take them all out? And the short answer is no, we never do that, because you always want to have or preserve normal parathyroid function. And so in cases like that, people get what's called a subtotal parathyroidectomy, where either one gland in its entirety or a portion of one gland is left in place so that it can provide normal function. Okay? Next question. I had papillary thyroid carcinoma and I had my thyroid removed. I had a total thyroidectomy. Now my doctor suspects parathyroid disease. The question is, how is this possible? As I said before, the two things are not related. Thyroid function and parathyroid function are completely unrelated glandular systems. The hormonal axes do not intersect. And so you can have disease of the thyroid and have it treated and be diagnosed sometime later with hyperparathyroidism. It should still be treated. It's a bit more complex because of the previous thyroid surgery, but it certainly can be treated with experienced surgeons who do a lot of reoperative surgery, like the surgeons at this practice. Let's see, that's kind of a long question. I am a 65-year-old female. Over the past 12 years, my calcium has been in the 10 range. We would consider that elevated. For adults above 40, just to give context, adults above 40, really above 30, having calcium levels above 10, we would consider that elevated. So over the past 12 years, my calcium's been in the 10s. I was diagnosed with osteoporosis in 2022. I've been taking calcium and vitamin D daily for years. Could this be early or mild primary hyperparathyroidism, even though my parathyroid hormone is only in the 50s? Should I pursue further testing? Again, we kind of mentioned this in one of the previous questions. Having an elevated calcium, which I would consider this high, meaning above 10, and parathyroid hormone levels in the 50s is consistent with primary hyperparathyroidism, likely contributing to this patient's osteoporosis. So yeah, I would say if the doctor managing currently isn't aware of this being a potential problem, then seeing an endocrinologist who's comfortable, which should be all of them, comfortable evaluating people for parathyroid disease, yeah, I would recommend that for sure. You likely have it and should have it treated. Okay, my mother has had multiple surgeries for parathyroid disease and continues to have high calcium and high PTH and many symptoms. She, not surprisingly, she no longer trusts the surgeons and is convinced she will never be cured. Are they having a hard time because the problem gland is hiding? Is cure just not possible for some people? It's hard to know without knowing the details. Some circumstances of parathyroid disease are very complex and are hard to cure for anybody, including us. In most cases of failed operations, it's because they were done by people who were relatively inexperienced. And having multiple surgeries and still having the disease makes it more difficult to cure somebody, but it's not impossible. And that's one of the things that I personally, that's my area of interest in my practice now, is evaluating and managing complicated preoperative cases just like this. The most surgeries that that have been done somewhere else that I've evaluated and operated on successfully, that had 6 previous unsuccessful surgeries. So it's certainly possible. If your mom is still suffering, then it certainly would be worth having an evaluation by someone experienced. I'd love to take a look at her case. You know, parathyroid.com, the intake process is really easy. So consider doing that, but it doesn't mean there's no chance for her to be cured, okay? That's an interesting question. We get a number of people each month that come here for surgery from other countries, and so this is a question from someone in the UK, I'm assuming. The question is, would you trust anyone in the UK to do parathyroid surgery? Is it really worth traveling abroad to have it done? It's hard to answer that. I mean, I'm not familiar with UK surgeons, frankly. I can speak to this country where there's a lot of surgeons who do this operation who, frankly, aren't very good at it. And there are a lot of patients who have unsuccessful surgery and then are kind of left not knowing what to do. So I would tell you the same thing I tell people here. If you're considering having surgery for parathyroid disease in the UK, find the most experienced surgeon that you can. Is it worth traveling abroad to have it done? It's a big deal to fly that far and to financially to do it. But it's your health, and so people with the means fairly frequently have made that decision to come here. So it's something to consider. If you stay in the UK, find them, again, same as in this country, find the most experienced surgeon that you can to take care of you, okay? Let's see, what happens after I have the calcium and PTH panel done and they are both elevated? Is that enough to become your patient? Yeah, the short answer is yes. I guess if the question is, do you need more testing? Do you need imaging tests? The answer is no, you do not need imaging. Imaging does not play any role in making the diagnosis of hyperparathyroidism. That's an important point. It has no role in the diagnosis. There's no role of imaging in decision to treat this disease. And so to be evaluated by any surgeon, including us, all you need is the biochemical data that confirms that you have hyperparathyroidism. So if what you're saying is you do have that data, then there's nothing else required. If you're interested in becoming a patient here, then yes, absolutely. Go to the website and do the intake process, and we'd be happy to take care of you. Nothing else required. This is prefaced by saying weird question. It is kind of it's an interesting question. From a big picture perspective, I'm wondering if there is some physiological purpose of primary hyperparathyroidism in the aging human that is potentially being overlooked, or is it clearly a disorder disease process? That's an interesting thought. I would have to say that, I don't think there's a physiologic purpose in aging people, because pretty much everything this disease does hurts you. Additionally, Julie, who sets these up for me, she made a good point, which is, teenagers get this disease as well. I operated on someone in there who was 14 last week. The youngest person I've operated on was 10 years old. So it's an interesting thought, but I think the answer is no. This is a disease process. Okay, on your website, you talk about doctors who confuse primary and secondary hyperparathyroidism, that have people supplement with vitamin D. I see this a lot. I think this is from a doctor. Can you please explain how this can skew lab results and the effects of unnecessary supplementation? I kind of answered this question earlier as a similar question from somebody else, but we get vitamin D confusion questions all the time. Really, every single time we do one of these Q&A sessions, we get questions about vitamin D. To reiterate, if your calcium is high and your PTH is high, it's likely that your vitamin D, your 25-hydroxy vitamin D levels will be low. Parathyroid hormone converts vitamin D to its more active 1,25-dihydroxy form. Okay, that's one of the ways that parathyroid hormone makes more calcium available in your bloodstream. Specifically, vitamin D facilitates absorption of calcium from dietary sources, from your gut. So if you're overproducing parathyroid hormone, you are constantly depleting your 25-hydroxy vitamin D levels by converting it to its other form. So it's expected to have a low vitamin D. This is not secondary hyperparathyroidism due to vitamin D deficiency. It's completely different. The key difference is your calcium levels. If your calcium levels are low and your vitamin D is super low and your PTH is high, then yes, this could be vitamin D deficiency causing a secondary PTH elevation to compensate for that. If your calcium's elevated, then you have primary hyperparathyroidism, and it's expected that your vitamin D will be low. Supplementing your vitamin D is not necessary, can be detrimental, and you don't need to rule out secondary hyperparathyroidism due to vitamin D deficiency. This is primary, okay? Hopefully that explains it. Again, this is, it's kind of a funny question. My surgeon can only find 3 parathyroid glands during my surgery. Does this mean I only have 3 glands, or is it likely that there's a 4th gland that's in an unusual location or hiding somewhere? I guess my private I don't always, I can't always identify all 4 parathyroid glands during every operation, even though that's my goal. Some parathyroid glands are located outside the areas that we can get to through a normal surgical approach. The parathyroid gland, the nature of the embryology of parathyroid glands is that they're not always in the same place. That's part of the challenge of parathyroid surgery. Usually that variability is accessible, okay? But sometimes it isn't. Sometimes the glands can be out of where we can get to. They can be up under the jaw, they can be fairly low in the chest, etc. And so most likely if a gland wasn't identified, it's in a less common place, especially if you had an experienced surgeon who understands the anatomy and the embryology. Is it possible that people are born with 3? I guess when I don't find a gland, I'd like to think that it's just because the patient was born with only 3 glands. Not that I failed to find one, but in most cases, probably it's just a gland in an unusual location. That's a good question. Okay, here's another one. Why do doctors want to monitor for a while first before surgery? That's a really good question that I don't really know the answer to. It's a frustrating one because for things that I've mentioned already, answering some of the other questions, if you have hyperparathyroidism, it's not going to get better without surgery. The longer you have it, the worse it is, the more time it has to damage your body. And an analogy I like to use with patients in the office or when I'm talking to them on the phone doing consults is with hypertension. And I mentioned it, I think, already today. Specifically, these 2 disease processes cause a lot of the same problems: renal failure, stroke risk, heart attack risk. And so if you go to your doctor and your blood pressure measures 200 over 100 or some really high number, they they will not be happy with that. They'll say, oh, your blood pressure is way too high. That's bad. What they don't say is, let's just keep an eye on it. When you stroke out for the first time, come back to the office and we'll start you on some antihypertensive medication, which, you know, I mean, that's ridiculous, right? But they do the same. That's what they tell people with parathyroid disease all the time. Hey, you have hyperparathyroidism. Yeah, by the way, this causes, you know, bone loss, risk for renal failure, risk for stroke, risk for heart attack. Let's just watch it until you what? Until you have osteoporosis, until you've had a stroke, until you've had a heart attack. It doesn't make any sense to do that. I think why they do it sometimes is, you know, a lot of surgeons in this country are not very good. They're not good at doing this operation. So I think a lot of doctors have had poor outcomes for their patients, and so they're hesitant. But it doesn't have to be a big deal, or you don't have to have poor outcomes. You just have to, you know, find experience centers like here. The other thing I would say is, you know, for this, let's wait and see, is the damage that this disease causes is not reversible. Bone loss is. Most people after successful parathyroid surgery will show an improvement in their T-scores on their bone density scans. But if you've had damage to the kidneys, if you've had damage to the vessels to your brain, if you've had damage to the vessels to your heart, that's there. You're stuck with it. There's no data that shows that any of that reverses or gets better. Okay, so again, the diagnosis has been made. It should be treated. Okay. There's some more. Thanks for those of you who are sending your questions in here live. Okay, I had 2 parathyroid glands removed in August. Calcium is now 10.4. Does this mean I have another tumor? 10.4 is higher than what we would expect after success or curative surgery. In the early, August is last year, so it's been about a year. It's concerning without knowing the details of the surgery, et cetera. It's certainly something that needs to be looked into. If your doctor or surgeon or whoever's managing you hasn't really paid attention to this, they may not care about it because 10.4 will show up as normal in most assays. Most calcium assays will include up to 10.5 as normal, but again, for adults that are 40 or above, really 30 or above, as I said before, 10.4 I would consider elevated, so it's suspicious. Okay. Next question. After surgery, do I need to continue to be monitored for calcium and PTH? If so, how often? I mean, this is a good question. If you've had for our patients who I assume have had a straightforward surgery, we usually know before the patient leaves the hospital if they're cured or not based on the findings during the operation, and we do check a parathyroid hormone level in the recovery room about 25 minutes after surgery. And so if the parathyroid hormone is dropped into a acceptable range and we've found all the glands, et cetera, things are straightforward. We still check a routine set of labs about 1 to 2 months after surgery just to make sure that everything looks okay. If those data look okay, then, you know, other than having your annual check with your doctor, you know, who usually will check your electrolytes, including calcium, that's really all that needs to be done. Doesn't need to be done more often than that. You don't really need to check parathyroid hormone levels. Just the calcium during your routine sort of annual physical is adequate. The next question relates to symptoms. How quickly do symptoms like brain fog and bone pain resolve? What about more serious damage like kidney disease and osteoporosis? Okay, you know, when I explained sort of parathyroid disease and parathyroid physiology early on in this Q&A, one of the things that I talked about the damage to the body that can happen, I didn't mention the symptoms, which is an important thing to mention. The disease can cause a lot of fairly significant symptoms that can affect your quality of life. Chronic fatigue, bone and joint pain, neurocognitive deficits like inability to concentrate or short-term memory loss, mood problems of various types like malaise or depression or anxiety or irritability, and there's a number of other ones. So how quickly do symptoms resolve? Usually fairly quickly, in the order of days to weeks, like a few days to a few weeks, and it depends a little bit on the symptom. For example, bone pain goes away instantaneously. It's pretty cool, it's pretty fun actually to see patients, how happy they are when the pain goes away, because it's like you flip a switch off. If you're successful and the bone pain is related to parathyroid disease, it goes away instantly. The other things, as I said, usually within a few days to a few weeks, so pretty quick. Osteoporosis is a months to years long process to show improvement in T-scores. Kidney disease does not get better. Okay, it's a good question. Thank you. This is a question relating to the anesthesia we use. What type of anesthesia is used on your patients? How much time under do you intubate? So these are all kind of, anesthesia-related questions for the most part. The best way to describe the anesthesia we use here is a light general anesthesia. Okay, you're unconscious. Propofol is used, which is used for pretty much everything these days. If you have a colonoscopy, for example, you will get propofol, and that renders you unconscious. So that's general anesthesia by definition. For bigger operations, general anesthesia involves the following things: being unconscious, usually being paralyzed, being on a ventilator, and being intubated endotracheally. For our operations, you do need to be unconscious. We can't have you moving suddenly. It's unacceptable. So you're unconscious, so it's general. But you're not paralyzed, you're not on a ventilator, and most patients are not intubated. Occasionally that's required, but most patients get a less invasive airway control device. How much time under? It varies, obviously, but most surgeries take about 15 to 30 minutes for us to perform. The third part was the intubation. I already answered that. It's a good question. This is a hard one to answer. What does a normal parathyroid hormone level look like in a person with no parathyroid issues to disrupt the system? There's a normal range. If you look at a parathyroid assay, there's a normal range. Typically, it's between 15 and 65 picograms per milliliter. That's the unit, the concentration that's used for that, for that test. However, parathyroid hormone can fluctuate quite a bit, depending on what's going on in your body. For example, if your calcium is low for some reason, some people have absorption issues, etc. And if your calcium is running low in your bloodstream for whatever reason, it's normal to have a higher than normal PTH. That's its job. You're going to make more parathyroid hormone to compensate for that low calcium and return it back to normal. So, what is a normal parathyroid hormone level? Just depends on what's going on in your body. Having a high PTH or a PTH that measures above the normal range on the PTH assay does not mean that you have a parathyroid problem. Okay. And let's see, this is the last question we're gonna have time for. What's the best way to test if a parathyroid gland is bad or has a tumor? I'm not sure if that means during the operation or in general. I guess I can answer both. In general, like to tell if you have parathyroid disease, as I mentioned before, it's entirely based on biochemistry. So these are neuroendocrine tumors, and they change, because of that, they change your biochemistry in like a very specific way. So lab data tells us whether you have a parathyroid tumor or not, okay? And we're talking specifically about the relationship between calcium and parathyroid hormone. That's the lab data you need to make the diagnosis. So that's, if we're not talking about during surgery. During surgery, in this practice, we do two things. There's a visual inspection, and to be honest, parathyroid tumors are very obvious, compared to normal glands are obvious. So we don't need to sort of test functionally a parathyroid tumor to figure out if it's a tumor or not. They're obvious. The other glands that we identify during the operation are tested functionally based on the amount of radioactivity that they've absorbed from the tests we do before surgery, the sestamibi scan that all of our patients get right, but fairly soon before their operation. And so the amount of radioactivity in those tissues, it correlates to how much of the radiopharmaceutical the glands have absorbed or taken up. That correlates to their metabolic activity and therefore their parathyroid hormone production. So it's a radioactivity measurement that correlates to their function. And so we know what normal tissue, normal function should have absorbed. And so it's measurable. And so the glands are both inspected visually and they're tested functionally in that way, okay? That's all the time we have. Again, thanks so much to everybody who joined. Thanks for the questions. The questions that you all send in help a lot of people. I get comments from patients who come in for surgery pretty much every day who say that they've seen some of these Q&As on YouTube or live, and that they find them very helpful. So thank you again for joining. We'll do another one of these in a month or so, and have a great rest of your day. Thanks for joining us.